This video is on common skin disorders, and it doesn't get more common than acne. Acne is just clogged pores, and your pores is your hair unit. So your hair, your pili, muscle, and your sebaceous gland. Sometimes if your sebaceous gland gets a little too, overzealous, then it can clog your pore. Yeah, and when it clogs, then a bacteria called propionic bacterium acnes, which is read as prop acnes, will infect that pore, and you get inflammation, you get pus, you get a pimple. So that is all acne, and it's more common in puberty because your sebaceous glands are hormone sensitive and you have more hormones, especially androgens, during this time. So I just write increase with androgens. Some ways you can treat it: just hygiene, just face washing, benzoyl peroxide, that just makes free radicals and that destroys your bacteria in the area. You can also irritate your face, so you gotta be careful of that. And if it's very severe, you can try things like vitamin A. Vitamin A seems to reduce sebaceous gland activity and can also reduce keratin, so kind of reduce that clogging, but there are a lot of side effects to vitamin A. So that's for more severe acne or cystic acne. So vitamin A can also be used as a treatment. Next up, rosacea. Rosacea, I want to talk about rosacea right after acne because it can look a lot like acne. It causes these pustules, these kind of pimple looking things, but it's seen more in older adults. And there's some sort of trigger commonly, usually from certain foods or certain weather, and it causes these breakouts. So I'll write trigger. And whereas acne kind of goes away when you get a little older, rosacea stays, and this chronic trigger, chronic inflammation can cause deformities, especially in your nose. We call that rhinophyma. Phyma just means nodule, so you get this really nodular, bulbous nose deformity. So right, deformed nose. That's another giveaway. You don't get that with acne, okay? Some treatments include metronidazole. They propose as more anti-inflammatory than antibacterial, but just something to keep in mind. Next up on the list, atopic dermatitis, better known as eczema. Atopic is a type 1 hypersensitivity reaction. Do you remember anything else that's atopic? Things like allergies, allergic rhinitis, things like asthma. So patients that have this are more at risk of those things. We call that the triad. So atopic eczema, you can get allergies, and then asthma, that's the triad of atopy. So just for asthma, rhinitis. Commonly seen in the face in infancy, and then seems to move toward the flexors. So your flexors, one of the proposed mechanisms is your flexors are a little thinner skin, and when you cause flexion, it can cause skin breaks and antigens can come in and cause this type 1 hypersensitivity reaction. So it's seen more in your flexors, commonly your elbow flexors or your wrist. Another type 1 hypersensitivity reaction is urticaria, aka hives. Hives is also a type 1. Both of them are type 1. Hives occurs when there's a trigger and it causes type 1 hypersensitivity reaction. So mast cells degranulate, release histamine, and the histamine causes vasodilation, causes swelling. You get these hives, these swelling skin lesions with trigger. I actually have this, I get cold induced hives. So if I'm out in a cold temperature for too long and I come inside, I know I'm gonna get hives, basically. Just hives grow on my skin and I'll warm them up and they'll go away. You can stop these if you want with antihistamines because it's due to histamine release. I'll just write antihistamines. Antihistamines. These are all type 1. How about some other types? We have a lot of type of hypersensitivities. Let's not neglect those. So we can have a type 4, and that is contact dermatitis. What is type 4 again? Can you remind me? If you can remember, then you should know what goes on in contact dermatitis. Contact dermatitis, you're exposed to some sort of antigen and it attracts T cells and that activates macrophages. So T cells, all right, trigger, turns into T cells, present in macrophages. And you get this local inflammation to whatever site was touched by that trigger. So the most common ones are things like nickel. If you have like a nickel belt and then you have a little rash right there, or poison ivy. You touch poison ivy, get a rash. Now here's the thing, when you touch poison ivy, you don't get the rash right away. Type 4 is also known as late hypersensitivity. So it's later, it's a late reaction. If you see a reaction right away, you're thinking type 1. Type 1 is immediate. So type 4 is like you hit that poison ivy, you don't see anything, and then a couple hours later you develop that rash. Moving on, verruca. Verruca is warts. Warts are due to HPV infection. HPV is a nasty virus. Not only likes to infect your cells, but it likes to mutate your cells, creates proteins that mutate your DNA. And because it mutates it, it can cause these warty growths. And low risk strain HPV causes these. So things like 2 and 7 cause common warts, basically the warts on your hands. 6 and 11 cause genital warts, warts on your genitals. And then the higher risk strains will mutate your cells so bad you're not even worried about warts, you're worried about things like cancer. So the low risk strains of HPV cause warts. And the last thing I want to talk about in this video is psoriasis. Psoriasis is a multifactorial disease. No one really knows for sure what causes it, but it seems to be heavily revolved around abnormal immune function. Especially these T cells that are all over the stinking place in your epidermis, T cells in skin. And they cause reaction, they release proteins, release cytokines that increase keratinocyte proliferation. So increase keratinocytes. Because of that, you get increased keratinocytes, increased keratin, increased skin. And so you get these silver plaque-like skin. All right, silver, they always say things like plaque-like and silvery. Plaque-like skin. This thickening of the skin. Again, the mechanism is heavily revolved around this regulation of immune function. Don't forget, we already talked about psoriasis earlier. Do you remember when we talked about it? We talked about it when we talked about zero-negative arthritis. Do you recall that? And all zero negatives are associated with a special HLA. Do you recall it now? HLA B27. Never ever forget that psoriasis can cause joint damage. Never forget that. I've gotten so many questions wrong. And so learn from my mistake. I've gotten so many questions wrong because I keep forgetting that psoriasis causes joint damage. Okay, so it's part of the HLA B27 seronegative arthritis. Don't ever forget that, please. Now, what are some signs? You'll see these plaques in your extensors surfaces, so like the back of your elbow, not the flexors like eczema, but your extensors. Also, if there's trauma in the area, it seems to create more plaques. I don't know if the trauma is a trigger for these abnormal T cells, but it seems to build around trauma, so I write trauma. And also, just because the skin looks thick doesn't mean it's actually thick and sturdy. If you rub the skin to plaque, it'll actually scrape and cause bleeding. We call that Auspitz sign. Auspitz sign. Some histo findings. Histo. You can have acanthosis. What is that? I'm not going to write it down. I'm hoping you remember. What is acanthosis? That's increase in your spinosum. Good. Parakeratosis. What is parakeratosis? That's increased corneum plus retention of nuclei. And then lastly, you get Monroe microabscess, and I don't expect you to know that because we haven't talked about it. It's basically pus and neutrophils that's gotten into your stratum corneum because it thinks some sort of inflammation is going on. That's Monroe microabscesses. And then again, the next picture will be in my notes. Just make sure you see all of those in the picture. All right, that way you can really pinpoint histology. How do you treat it? Because it seems to be an autoimmune disease, you can give corticosteroids. You can, if it's not working, you can kind of increase the severity of these drugs. So things like methotrexate, things like TNF alpha inhibitors, but those all come with side effects. You can also give UVA light. UVA is just radiation, kills your keratinocytes. So it kind of lowers that. And you can give a drug called Sorelin. Sorelin is a drug that increases your ability to absorb UVA, just kind of builds on that UVA pathway. All right, so those are common skin disorders. Hope you enjoyed the video. Thanks.